Good evening, everyone. Here Imran Abbas. Again, we are live, and I am live from Dubai. And today we have Professor Michael Kramer. Professor is from Germany, and now he's practicing in Tashkent, Uzbekistan, and really so much excited personally myself to know more about his experience, especially metabolic surgery in low BMI diabetic patient. My viewers, as you know better than me, we have started this academic activities with MGB-OAGB, interview series of MGB-OAGB, then safe sleeve gastrectomy, then Roux-en-Y, and now we have started this interview series with Professor Alper Chilik, who is well-known bariatric surgeon and metabolic surgeon at the globe. And definitely his role is very important. And then we continue with Professor Surindra Ogale, and we will continue. Also, last week we had Professor Antonio Torres. And also now it's great honor to interview such a prestigious figure. Sir, over to you.
Thank you so much, Imran, for your wonderful introduction. Thank you so much. It's a great pleasure to share our experience with all the participants tonight. For me, it's tonight. Maybe for some is tomorrow in the morning. Yeah,
maybe yeah. Some
yes.
in front of this globe. So, but according to as you have mentioned, so in Dubai now 10 p.m. and definitely I think in Tashkent also 10 p.m. same
no
time.
11. No 11. It's
now 11 p.m. Okay. So just sir, we overall we have divided these questions in three parts. One is pre-op and patient selection. In my opinion, that is the most important. Then we will touch your technical points and which type of surgery, metabolic surgery you prefer. And then we will talk about your results of this surgery. Sir, first of all, we are interested your brief introduction and your journey of bariatric and metabolic surgery.
So thank you so much, Imran. My name is Michael Kramer. So I'm, of course, originally, you hear my accent, from Germany, and I'm doing bariatric surgery since 2005, 17 years now. And the topic tonight is a wonderful topic. And you talked about Antonio Torres, one of my best teachers. I know Antonio since 2006. And another teacher is Sergio Santoro and Tarek Mahdi. So all these people are very much involved in metabolic surgery. And actually Martin Büsing, one very important colleague in Germany, introduced or invited all these guys together to Recklinghausen in 2019. And in this year, for me, it was a wonderful experience, hopefully for some of our participants during tonight audience, that you get ideas and you say, that is what I was waiting for. I have done something for many years, but I haven't seen the next step. And sometimes it's simple just to add some new knowledge and you say, oh, now it's logical. And this is my motivation. So a lot of these ideas and slides are really from my teachers. So it's not everything on my own hat. So I don't want to take the applause from the floor for things I haven't done. But I think these slides, maybe we can share later on, Imran, are very important for didactic. We talked about, we want to teach a little bit, we want to help everybody. So, and of course, it's very important to ask everything. And since 1 year now, I'm here in Tashkent, Uzbekistan, to do the same what you talk about, that we want to make medicine a little bit better here in Uzbekistan. And it is a wonderful country in Central Asia, and 35 million people are living here. And we have a lot to do, and diabetes is a huge topic in these countries too, maybe, but this is not, I'm not specialized in cost effectiveness of our treatment to talk about. This is maybe a special topic, but we face diabetes here in the country. Of course, we have Coca-Cola, Pepsi-Cola, and all these fast food developments now. And it's only a question of time that diabetes is exploding and spread it over the country, or it still is. And that's why I think this is a very important topic. Yes.
Sir,
So,
so much thanks for your brief introduction. And definitely, I am talking with someone who has experience of metabolic bariatric surgery more than 1 decade, and also
yes,
experience.
I was very young when I
No, no,
started. Now I'm old.
no. Because of this interview, only overall, this is in light mood. And what is the difference from webinar? So in webinar, we have not such a time to explain our experience. So due to this, we choose this interview system. So sir, regarding the patient selection, how you select your patient for metabolic surgery? If you are interested to show your slide, your presentation as it is easy for you, or you can explain.
I think so. Maybe first I answer and then we start with the slides. I think this is very good. So in the slides, there is a little bit the answer on your question, Imran. I think for me, it is very important that I work together with diabetologists. So at the end, when we talk about our patients, they are all patients who come from a group of experts, I would like to say. So in my case, not the patient is coming and say, Michael, I have heard you are a wonder doctor and or you make miracles. No, it is that the diabetes specialist says, we have done everything. Is there any other chance to help the patient? And here I think it's a very important information at the beginning that we should choose the patients wisely. But then we have a very, very nice option. And this is maybe what we can show. So now I would like to share my slides with all of you.
Yeah.
Can you see my slides?
Yeah, sir, excellent. We can see.
Perfect. So this slide is so simple, but it is really a slide from 2007 or 2006. And I have shown this slide to say, we are a researcher. I started my career. I was allowed to start my career in University Hospital of Tübingen in Germany. And this is a famous place to do research. And we really had a wonderful research or still have a wonderful research program. So, and this slide was in my presentations. But actually, I haven't understood so much in detail what I have shown. And today you can say, yes, what we see here is a very important background for our metabolic surgery. This is the PYY is written, GLP-1, yeah, all these things we will face in this small presentation, and they are very much influencing my approach for metabolic surgery. But in these years, I have shown this, sorry, I was not able to interpret this in the right way. For me, and this is very important, is the philosophy very much influenced by Sergio Santoro. I have to name him because he's maybe he will speak in this group later on, and he's a wonderful person who has done a lot of research and he has more experience than me. And Sergio presented this idea that you have an upper part and a lower part of our small bowel. And for all people who want to do metabolic surgery, I think it is very important to see that in the upper part, you have an increase of production of glucagon, sugar, and insulin. This is the job of the K cells. And in the lower part of the small bowel, you have a decrease of production of insulin, and you have to block glucagon, and you have to stop the glucogenesis. So on the other side, there are other, and today Sergio published, I don't know if Imran, if you have seen this, as a new presentation about PYY, and this is in our group of bipartition. And I think this is so important. All these metabolites are more and more important as more we know about what we are doing. Yeah. So for the participants here in this interview, it's very important that we see there is an upper part and a lower part, and they have a function from the beginning, from the dinosaurs. Even dinosaurs have special division of these parts, upper and lower part. Oh, sorry, let's see. So when you say what is the job of the upper gastrointestinal tract, it's the avoidance of a hypoglycemia. This is very important. So therefore, the production of GIP produces a secretion of insulin and glucagon. Together, these both products feed our hunger cells. So we are hungry, we want to eat something. And this function does not block gastric emptying. So the body wants to have more, eat, eat, eat. Yeah? So gastric emptying is not stopped. We are hungry, we want to eat more. And it is not producing satiety. And therefore, we can say this upper GI tract is not specialized to end the meal. So the GIP in translation, I always have to do this in the same way. I'm not so intelligent, so I need the translations: glucose-dependent insulinotropic polypeptide. This is a very important messenger of the upper GI. And the hyperstimulation here in the upper GI, so when the food goes to the stomach, to the duodenum, and the upper ileum, then you produce insulin resistance and heterotropic fat buildup if you eat too much sweet things. Yeah, this is a finding what is not very new. This is an old finding. And now it's very important for me when I talk about this process is what is the job of the lower small bowel. And maybe I can tell you why the group around Sergio, why they found the function of the small bowel. So the prescription was very simple. If you have a gun injury of your small bowel, you have to, or of the small intestine at all, you have to remove sometimes parts of the small bowel, and you have to connect the lower small bowel with the stomach. And they did this in Brazil and in the 90s. So, and afterwards, in the follow-up, they found that people who had diabetes before this accident had a wonderful benefit of this procedure. And now they started to think about, okay, what is happening? We brought only the lower small bowel to the stomach. And this is helping to improve the diabetes situation so much. And then they started the research we are talking about today. Yeah. So is the small bowel of the lower part, so the terminal ileum, we can say, is said to be very efficient in reducing hyperglycemia. GLP-1 in our days, it's synthesized in Victoza, Saxenda, something like this, and this blocks glucagon secretion. So we need, or we use this GLP-1 from the diabetologists to treat our diabetes patients. And here, it is natural. It is a function from our human nature. And now, this is interesting. These hormones, they stop gastric emptying. Yeah, they produce the satiety and can therefore end a meal. This is a little bit the effect of these injections of GLP-1. Imran, is that okay? Do you have questions?
Yeah,
here?
excellent. Sir, excellent demonstration, definite. And you have demonstrated the role of foregut and hindgut theories, and also that was followed by Professor Michel Garnier, and also as well at that time in 2004, first time when Rubinio and Michel Garnier, and this was the concept of foregut and as well as hindgut. And then they mention, so the small bowel is one of the biggest endocrine, and then mention, so as you have mentioned this. Sir, please.
So when we talk about, and I have forgotten to talk about Michel Garnier. He is one of the most important influencer of my ideas, of course, too. And thank you that you talk about him, because he really has the same findings that you remember the story that he said we always did the BPDDS, and then I stopped it to do it together, and I separated, and now the sleeve gastrectomy was born. That was the story of his situation. And And here we can talk, so when we talk about metabolic surgery, I think metabolic syndrome means GIP versus GLP-1 and PYY. And so you have a hyperactivity and an ileal hypoactivity. And this is the proximal distal imbalance, what we say. And please remember me, later on, I will talk about the long small bowel. In many of our patients, we find a very, very long small bowel, and therefore, this is a factor for developing diabetes. This is a slide, maybe someone, I hope it's not too complex, but I want to, just the message is, in the gastric part, we feel hunger, and then ghrelin goes up. And GLP-1 level, PYY, all these levels are very, very low. So the stomach empties fast, yeah, and so here it's producing only this intestinal satiety, what is not very good to control. But when the food arrives in the lower part, GLP-1, PYY is increasing. We have a slow stomach emptying, and now we have the feeling of fullness. Yeah. So, and this is from the nature that we stop our meal. But first we need activity to hunt a bear or whatever we have eaten 30,000 years ago. Yeah, this is the mechanism behind, and we have to understand even in our modern times. Okay, and when we talk now about the common procedures, and you ask me what is your favorite, or how do you go on this field of all these different surgeries, then of course for me, I'm coming from the sleeve gastrectomy. You talked about Michel Garnier. That was my influence. I started with sleeve gastrectomies 2005 in Tübingen, and Rudi Weiner started 2004. So we were really at the beginning of sleeve gastrectomy. And why I'm still today, like, maybe I can say I love this procedure, because it preserves the natural way of the food. This is my topic for my surgery, yeah? And you talked about MGB and Roux-en-Y gastric bypass, two very, very solid, very popular procedures. But when I met Sergio and all these guys from the bipartition group, of course, the disadvantage of bypass surgery is that we exclude the duodenal passage. And I'm doing also a lot of endoscopy. Yeah, so I'm an endoscopist too, for flexible endoscopy. And I want to see my papilla all the time. Yeah, so that's why I really do Roux-en-Y or bypasses in a very, very few level, because if I can do sleeve, I do it. But, and this is another story, has nothing to do with metabolic syndrome. Of course, the Achilles tendon of sleeve gastrectomy is the reflux. So then, on the other side, you have talked about Antonio Torres. I have started metabolic surgery with Zadi bypass. Yeah, and this is an excellent procedure for wonderful weight loss. You have to be experienced from my point of view, yeah, because we are working in the duodenal area. I think this is not something for beginners, yeah, and this is not a surgery you should start with. Now, this is a take-home message from my side. But of course, with the Zadi bypass, and Antonio maybe has talked about it, or I'm sure he has talked about these excellent results, you have wonderful control of all these metabolites of the terminal ileum I have shown before. The disadvantage, you have a long exclusion of the small bowel of your upper small bowel. And what I face with my Zadi patients most of the time is a long time with diarrhea. And this is another very important message or point to discuss. I like if something is reversible. Yeah, if we can change, if we can modify. So this is my philosophy, and this is what I want to keep everybody in mind. Please keep in mind that we have still other options. And then, of course, when I have seen the Zadi bypass, it was opening my eyes. I said, okay, that is the solution I need. I have control over gluconeogenesis. but I have advantages I have never seen before. I reduce the pressure of the stomach, and I can do it. I can remove it. This is unbelievable. Yeah. So this is how I came to this kind of surgery. And I do this now since really I have seen this idea in February 2019. And I came home to Munich, where I come from. And in March 2019, I did my first patient, but as a revisional surgery. So this is maybe another topic we have to talk about. Do we do it as in one step or in two steps? This is an open discussion. I like today, because the results are excellent, I like very much to do it in one step. But for metabolic surgery with low BMI, because today we talk about low BMI, maybe we have to be a little bit careful, because maybe sleeve gastrectomy is okay, but I love this terminal ileum effect. And I really see this for, yeah, I can say for all my patients. And that's why I, even in lower BMI, like this effect, because the diabetologist has done a lot of work before. He will not send the patient directly to our hands. And that's why I think we can do it. So this is again the example for diversion operations. I think all of our participants know about this. I think it is very important that the limb is round about 300. Sergio is adding this information right now too, because the effect of the hormones, this is maybe another take-home message, with 300 is completely enough. If we go too low with the distance, we face more problems like diarrhea. And Imran, you know this argument, of course, for many years. Diversion surgeries exclude intestinal parts to achieve malabsorption. They are not essential for correcting metabolic disorders. Why? Because they focus either on distal or on proximal changes. So how do we now achieve more potential? And the answer is, of course, bipartition. So get the message is easy. Get the undigested food into the ileum early, like in Zadi, they do the same. This is true, but they exclude a lot. And now with a connection, we can go directly into the terminal ileum with a part of the food, not all the food, only a part. And then you have a GLP-1 and PYY secretion, and then this secretion makes the meal smaller and stops gluconeogenesis and improves the effect of insulin. And a very interesting part is FGF19 and the bile function, bile acid. So if we stay as close as possible to the nature, so bile has a very important function in metabolic surgery, and more it's important. And the research is going on. There was a nice publication today in our group. Is it shared by Sergio? And this is really another important metabolic. So when you see this kind of surgery, it looks very simple. You have the sleeve, and you can add the anastomosis. This is a picture from Sergio, and I like this surgery because when we talk about the tips and tricks here for all people. So Imran, before we talked about, I think, because I'm doing now since 17 years, I think sleeve gastrectomy is not an easy procedure.
Yeah.
Yes. So there are a lot of pitfalls, and everybody thinks, it's easy, let's do a sleeve gastrectomy. But sleeve gastrectomy is a design surgery. The surgeon produces a new stomach for the rest of the life of this patient. And if he's doing twists, if he's not doing correct stenosis, all these factors, they have a very bad influence on the result. So sleeve gastrectomy is only for people who have a good teacher and they can learn how to perform. But sleeve gastrectomy in combination with the anastomosis to the antrum is, for me, wonderful, because now we have a direct connection from the antrum to the terminal ileum, and the duodenal part is still open. This is so important that the food goes through all channels. But with this, we can stimulate directly the ileum. And of course, because some part of the food is going maybe 30, 40%. If you ask me, I cannot tell you how many percent are going directly and in the other way. But we have a partial deactivation. Very, very important take-home message for everybody who is listening to this interview. The anastomosis should be not more than 3 centimeters. And the distance from the pylorus to the end of the antrum should be 6 centimeters. So then we start, and then we place the anastomosis right here, so that this is 3 centimeters, and then we have still 3 to 2 centimeters to the pylorus. And if we make the anastomosis bigger, we face protein deficiencies and a lot of diarrhea, and this is not good. There is a lot of experience about, so don't try to do the anastomosis bigger. But when we do, so my technique, because you asked me for the technique, what I do is really defensively, defense surgery. I do single sutures at the beginning so that I have really a perfect position of the small bowel in front of the antrum. I do it really with single sutures. I lose some time, but I'm fine with this. And then I have a perfect, really straight anastomosis over 3 centimeters. Then I close the defect with from Medtronic with the suture what is blocking himself with V-lock, and then I stabilize the anatomy with a second raw. So you see, this is very defensive. Many people just take the stapler, 2 minutes, bam, fire. If you ask me for results, I see not so many people, because this one anastomosis concept, and you are expert for NGB too. So this one anastomosis concept is always in the critic. You have a bile reflux. Okay, accept it. But when you do it in a proper way, my experience is we don't face so much bile reflux. If we face the bile reflux, then there was a question we can talk about in detail later. Then, of course, we have to cut the limb here, and we bring him 54 centimeters lower to the foot again. So the important message in metabolic surgery, and especially when we talk about low BMI. When we talk about low BMI, we want to have good control for our patients. In this area, nothing should be with risk. So for me, it is very important that the entire intestine transports food for vitamin deficiencies. So vitamins stay in the body. The sleeve is drained, so therefore we have a very, very nice benefit of reflux. Small step to the side, because I do a lot of reflux surgery. Now, when I have a redo surgery for slip Nissen, for example, I did it 2 months ago here in Tashkent. I do all the redo of the hiatal area. I place mesh, all what we do, and then I add the single anastomosis gastroenterostomy to this surgery to improve the poor stomach emptying after reflux redo. So I like this surgery, and Martin Büsing was very talked about that we do this gastroenterostomy since 130 years now. Yeah, but we have never combined. Yeah? So this is an important message, but we still, of course, need more research. This is a very nice topic for research. If someone is thinking about what can we do for research, I can motivate, go for it. This is nice case. So duodenal switch bypasses in SASI, we have shown, have the same stimulus, but our SASI concept or bipartition concept is safer and simpler. I think this is a very important take-home message. And for me, this is the most important factor. For low BMI, it's even more important that it's reversible. So if we do too much, we cut it from the stomach and the anatomy is back normal anatomy after sleeve gastrectomy. And I think this is, for me and my patients, and my diabetologists, a very important message. So my people I work together from the internal medicine side, they don't like if we change too much. Yeah, I don't know what is your experience in Dubai, but this is what they want. They are happy that we still can perform. Next point is ERCP, but it's very important that we have now a functional restriction. It's functional. It's not mechanical. We don't put a band somewhere or something like this. And the ERCP is still possible. I think this is for low BMI metabolic surgery, very important. And it is, yeah, very nice. We achieved excellent results of the DES. There is no discussion. Duodenal switch has very, very nice results. It was so nice because Antonio said that duodenal switch is closer to nature for him. And I say, Antonio, this is not closer to nature because you exclude a large part. There was a discussion between all of us, but I know him very well and I know he has excellent results, but the side effects of the SA-D are huge. So when you talk or when you ask me what is the option, very personal finding, of course, is that the sleeve gastrectomy is not enough in 30%. What regarding weight loss, I have to say, when we talk about diabetes here, of course, maybe the percentage is higher, that it's not enough in 50%. But the SASI sleeve, and I prefer 300. I don't want to see any diarrhea problems. Malabsorption is not existing. Endocrine effects are high, no exclusion. And this is the duodenal switch. The endocrine effects are wonderful, no doubt about, but we have side effects. And that's, for me, for low BMI, especially for low BMI, too much. So here you see, maybe all of you know about these results. These are first results, 6 years now, and I can reproduce the same, but I told about that since 1 year now I'm developing our hospital. So I have now no research team actually right now around me. We will do this when we open, but I'm 100% sure we can reproduce these data. Recklinghausen has shown they have exactly the same data. So we all see this kind of success. And for me, it's very important that the micronutrients are not affected by this kind of surgery. When we talk about low BMI, for me, it's more important. Yeah. And protein, here again, the message, anastomosis should never be more than 3 centimeters in the staple line. Very important message. Here comes a really special slide from myself. Imran, when you ask me, Michael, what are you standing for? So sometimes I'm in the position to do some things because I have the connection to my diabetologist and I have patients which I see for many years. And the SA-Yi single anastomosis, ileostomy. I don't know if it's published, maybe it's my idea, I don't know. I have a patient, I have done the bypass in Tübingen in 2009. And she was followed up by myself over years, over 20 years, almost, no, to 2021. And I saw the wonderful results from the bipartition. And then I said, okay, when you bring undigested food to the terminal ileum, so we can do it easily after one anastomosis gastric bypass or Roux-en-Y gastric bypass, we go 50 centimeter because behind, or when you do one anastomosis gastric bypass, 50 centimeters behind the gastroenterostomy. And then we do a side-to-side anastomosis. I prefer here 4 centimeters because now it's not dangerous for protein malabsorption. And then part of the food goes here, and the rest is going directly on the distal ileum. And what I can tell you is that people after bypass who fail, who still need a lot of insulin, and this was my patient, she needed a lot of insulin, and my diabetologist, he did everything, and he's really an expert. And that's why we started. And I said, okay, I have this idea. And it's reversible again, so we don't risk too much. And all these, so I did it, and it was easy performance, 3 trocars, 1 hour, really not a big deal. And they are all successful. So I started and I saw weight loss, 10 kilograms, diabetes improvement. And I did it not only for diabetes. The first one was really a diabetes patient, and the other ones are weight regain people after Roux-en-Y gastric bypass. And now I have a message from one patient. I did it in the last year. She lost with this simple technique 26 kilograms after weight regain. So just for all of you, here is no research about, this is just an idea. I think we can do it because the research around is wonderful. It's reversible, it's simple. So I don't prefer to make the anastomosis smaller or something like this, because I can do. I'm teacher for endoscopic suturing, but I'm not happy with these kind of results. And when you see, that was the most important message. When you see all my failed bypass patients, they have all a length of the small bowel in between 8 to 11 meters. Yeah, it was a very, very long small bowel. So what was the effect of the bypass? The bypass was in the upper GI, but the effect of the terminal ileum was not taken place because of the length of the small bowel. And that was exactly what all these people are telling me. I'm never feeling full. I have this problem. And after Zaye, they have it. But here, research is necessary. Don't ask me for my data. This is really preliminary results, but I'm completely happy. Whenever I have a patient who asks for this kind of procedure, I can say we can do it. Yeah, this is all of you know about ESG, endoscopic suturing. Short picture, I don't think this is for metabolic surgery, low BMI. I'm very critical here. That's why I want to show. We are a teaching session because the long-term results are not so stable, but you don't cut anything. So that's why maybe it's an option. That's why I want to bring it on the table. But you have to talk to your patients, see the long-term results is made critical. Now you can ask me, okay, we could combine it with a single anastomosis ileum connection. I have never done. It's possible, but you have delayed stomach emptying because of the sutures. The food stays longer. The transportation is stopped, but it is not metabolic for me. Questions? No, I go on. Iman?
Yeah, sir, excellent. So if it's, I think we must talk about some questions, so you can stop sharing. Then
Yeah.
it will be easy for me. So now you can stop sharing. You can click stop sharing. So really amazing and excellent demonstration about overall metabolic impact of bariatric surgery and how it works, especially for the control of metabolic syndrome. And you explain excellent. So this metabolic impact, and also we can add also that microbiota effect, because in any type of gastric bypass, this is aerobic routinely, because then this oxygen will go to small bowel, and also now the role of mitochondria and many other things still, I think, hidden, and maybe within some years, so we will see more and more about this metabolic impact. Sir, I will also ask some question about your technique, Saji, but now, because still we are, I am interested to know, so when you are going to do a metabolic surgery in low BMI, just first my question, are you doing?
So lowest BMI, because this was one of your questions, is for me 26.
26. So which tests are compulsory for you to go? So you will check C-peptide. Are you rule out in these cases LADAR, autoimmune impact? Is it compulsory for all of your cases or not? And how you, because this is very important, because patient want to know the prediction when we will do the surgery, what will be the result? So definite, though there are some criteria when you will do this, okay, I can go ahead any type. I am not talking now the technique, any type. But patient selection with BMI with 26 is very important because this is on borderline. So which tests are
Absolutely. Yes.
compulsory for you to do?
And here I think it is very important to talk about expectations.
Yeah.
And what can we predict? We can predict nothing.
Yeah.
At the end. But what we can say, that's why I say this group has not to start in our office. This group starts in the office of the diabetologist. And they come with the patient to our office. And then we talk all together about pros and cons. This is my style. I never do it. Hello, I do my surgery very safe. Come and we do it. If I would be the patient who's 26 and I would do a gastroenterostomy to see what is the effect. Maybe I would start with GLP-1, but we all know GLP-1 alone is not the complete answer. So we exclude all the other metabolites. So you could ask me, Michael, do you do a GLP-1 test? Yeah, so we could say, okay, let's give them Saxenda or Trulicity or whatever is the name for 3 months. And if we see an effect, maybe we can predict better results when we do the bipartition surgery or maybe do it in a switch. But I think we have to be careful with the expectations. Therefore, I'm so focused on the reversibility of the surgery, that if we do too much, we cut it off. And for these low BMI patients, I think, but this is not official, that maybe the gastroenterostomy, what I do for reflux people, is helpful. I think so. I think this is helpful. And then we can make the stomach smaller if we need. But these people don't ask for weight loss so much. And the effect of the ileum is enough to lose 5-10 kilograms. And this is more than enough for this group. But the metabolic, and then you ask me for how long should the diabetes? Yeah, this is the good question. I wouldn't say if you take insulin for more than 10 years, we have to bring the expectations very low.
Yeah.
Very low. 5 years, it's okay. But Imran, you see in our countries, when you have not enough money, this is now another question. This is maybe not the medical question. Then you say, okay, we can save insulin. And maybe this is another success. If you need 100 insulin per day and you after surgery can reduce to 20, maybe our people are very happy because they can save a lot of money. It's an open question. Here I cannot say you have to do it. It's just when I see my country here in Uzbekistan, I think, because I'm not experienced enough to say, let me answer the question in 5 years when I've done 100 surgeries. But right now, I would like to say, okay, the surgery is expensive and you need maybe 5 years to be cost effective. But sometimes you don't even have the medication. And then surgery is better. This is the discussion.
Definite, sir. Definite, sir. When we see the microvascular complication for diabetes, and you can see nephropathy, retinopathy,
yes,
and also coronary artery. So if you see, and if we convince our patient, yes, if we will not go for such a metabolic surgery, maybe in very near future, you will be going to dialysis or stents or something like this. So again, sir, so because what was my question? So we must check this beta reservoir with C-peptide. So when we have sufficient C-peptide and sufficient beta cell reservoir, and we must rule out any type of autoimmune impact, because sometimes there is LADA and also patient is suffering with diabetes and patient will not respond to such a surgical intervention then we can go ahead. So regarding this technical points, you have mentioned Saji, that was interesting, and also we have a lot of questions. We can talk, in my opinion, hours about this technique. So my just one question regarding this mesenteric defect. Are you close that defect? That
For the SASI, never.
no, I am not talking for Sasi. I am talking for Saji.
Yes, then Antonio in Madrid is never closing. I'm doing Antonio style. I don't close it either.
No, sir. My
But when
question regarding
for Zadi, so for Zadi,
not
Antonio,
not Sadi. So Roux-en-Y gastric bypass, and
then I close. Then you have to close.
No, then
yes.
you added. Then
yes,
you
then
added,
you have to.
Yeah,
yes,
then,
yes. And when I do Zayi, I close the mesenteric defect also.
Yeah.
Yes. Always when you bring, this is maybe a take-home message, I think, if you bring mesenteric parts together, you have to close the defect. Otherwise, you have twists and internal hernias. But if you put it on the big mesh, and if you have a nice design of the anastomosis, Antonio, me, some other guys, we never close the defect when it's in a nice position. But when you make departition, classical Santoro procedure, like a Roux-en-Y, close the defect. This is take-home message. Absolutely.
Yeah.
And do you do it with resorbable? I do it always with non-resorbable sutures. There is another discussion. Actually, we have started in Sydney 2006 to discuss about closing the mesenteric defect. I think we should take non-resorbable sutures. I don't know, what is your opinion here?
Excellent, sir. So definite. And when I was interviewing, I remember Professor Bruno Delemon in a session of Roux-en-Y gastric bypass.
Yes.
And we talked in detail. So now his technique, so that BP limb is longer than before. Now it depends on the patient BMI, and also associated comorbidities. If patient is suffering with diabetes with high BMI, definite his BP limb will be longer as compared to before, and also Roux. And also in case of, because also I asked this question from Himpen when I interview him about this Roux-en-Y and also this weight gain in Roux-en-Y. So that was also interesting because he was not in favor of distalization, because again, this is an issue. But in your technique, because this is not distalization, just you change, and that is the metabolic impact. When it's really interested for me, because when we will go for distalization, definitely there will be chance of more hypoabsorption and micronutrient deficiencies. But when you will do just this jejuno-ileostomy, so some particle, undigested nutrient will go to ileum, and you will take that metabolic impact. And due to rise of GLP-1 and PYY, then yes, due to their anorectic impact and that feeling, this is the satiety, and also and many other things that maybe still we have no idea about that. And this neuroendocrine impact of metabolic surgery. And in my opinion, this is interesting. Also, I had this question from Aaron Tashkent, because Aaron is doing only this jejuno-ileostomy in low BMI with Melissas. Melissas started this technique. And also I will interview Melissas, and also I will ask this question because they have a excellent experience. Just they are doing this jejuno-ileostomy, and they are achieving that target so of metabolic impact. Definitely, hopefully you can mature your technique, especially in these cases who are weight regain and also the reoccurrence of diabetes. So no need to go more aggressive.
Yes.
Just do this, and then you can achieve the target.
That's it. This is my philosophy.
Because as we know, minimal invasive surgery, also practically we must be minimal invasive.
Yes.
We must be minimal invasive, because if you are going to do more aggression and also revising all the surgery, the pouch, there is a lot of adhesions there, especially in Roux-en-Y gastric bypass, a small pouch there, and dissection. If there is no such a reflux or GERD, only weight regain or reoccurrence of diabetes, yes, we can achieve this target. Amazing. There is no doubt.
Super. So we do it together. Dubai, Tashkent study.
Definite, sir. Definite. In my opinion, this is the time, because nowadays, if you you agree with me, so diabetes and obesity is really, this is the real pandemic. Yes,
Yes.
just now we are going to finish this COVID-19, but COVID was here okay 2 3 years, but the real pandemic is obesity and diabetes. That is the diabesity. And how we deal with this now in 2022, I can challenge the most effective is surgical intervention. Maybe after 1 decade, yes. Again, I will ask you, so Michael, what were you doing at that time? So there was no need to go such a aggression. But in this era, yes, I can ask the best way,
Yes.
easy way, and speedy is surgical intervention. Sir, if you want to share any slide, please.
Because we are on the, let me see, we are on the
Here.
on the main street. We are on the main street. If we can finish, so because I think this is a very interesting talk tonight. And aftercare, you asked me about aftercare, or you have to talk. When we do metabolic, when we do bariatric surgery, we have to be there for our patients. And my German patients, they have my email address. They still can ask me any questions. So, and the patients here in Uzbekistan, they do the same. So in close cooperation with the general practitioner, this is the German system. In Uzbekistan, we don't have this system so much. So here more is in my own hands and the diabetologist. I think this is very important. In Tübingen, we had a board. We have talked with a psychologist. This is what I don't have in the last 15 years in my career. And I have separated specialists. If I see some problems, depression, something like this, of course, aftercare is important. I think you can agree. If we face some problems, please go to the specialist you think is necessary. Regular follow-up is not so easy in our country here because the people are not used to this. It's amazing. In Germany, they come. In Uzbekistan, if you are happy, you don't come to follow-up. So I always offer. On the other side, in Germany, I say, if you are adult, you can choose by yourself. I don't call you. My door is always open. If you want to come, I'm happy. If not, I will not call you. In Uzbekistan, I think we need another strategy because the people, if they are happy, they don't come. They don't complain about. So regular follow-up should be organized and is very important for the long-term results. Maybe it's very important, I think you can agree, in the first 2 years. After 2 years, people know much more about the situation. And I think when we talk about metabolic surgery, okay, we have to adjust the medication. We have to talk about diarrhea. Always I get sometimes questions, I drink my apple juice in the correlation 9:1 and I have still diarrhea, doctor. What are you doing wrong? And I say, please change 1 point apple juice and 9 point water, and then everything is done. They call back, oh, thank you so much for your help. But this is aftercare, and this is good when we are open. Yeah. And I think we should not delegate the aftercare too much to our young assistants, because sometimes it's important that we as experienced people see our patients, because we can find out much more sensible, here's something going wrong. Vitamin checks, of course. In Zazi, I don't face vitamin deficiencies. B12, vitamin D is, you are in Dubai, people are fully covered and they need vitamin D. For me as a German, it's impossible because you have the sunshine all the time. Yeah. We have the same in Tashkent. So vitamin D is really important for all of us. It's not special problem for metabolic surgery. Adjustment of the medication. Don't forget the sleep mask if you have sleep apnea. And if there is any problem, come to the center. This is what I spoke about. Another idea, maybe we have to think about for low BMI. Okay, just the single anastomosis. Research is necessary. It's just my finding from the reflux field. Open question. I just want to show you, this is my idea. And now everybody was so brave to listen to us. The summary: metabolic surgery for me is safe and offers very, very good results. I think there is no discussion around the world right now. I do it now for 17 years. Other people are doing longer, other not so long. But yeah, therefore, because the results are excellent, low BMI patients are options, are possible. But surgery, this is for me a very important message, should take into account the lifelong nature of the disease. And we should have options for transformability. That was my problem for proximal bypass. With the Zahi, now I'm fine with proximal bypass because I can adjust. Now I'm happy. Yeah. Interdisciplinary selection ideal. And for low BMI metabolic surgery requested. This is my point of view. So if I do it, I would like to have a diabetologist who is sharing my opinion, and we talk together with the patient about expectations. And you are completely right, all the metabolites, HbA1c, and whatever we want to see. Yeah, and because it's a chronic disease, stay alert. Yeah. And this will be our beautiful hospital here. We are still in the process. And yeah, Imran, thank you again for this great honor to talk in your very, very interesting group of people of our field. And you are doing so much for young doctors. And I support you anytime if you need, but it's a great pleasure. So yeah.
Sir,
thank you so much.
Sir, really, really appreciable for your support, and definitely you are always encouraging. And next week I will see you in Tashkent.
Yes, this is amazing. Yes.
I will visit your hospital.
Yes,
so next weekend I will be there, inshallah. Sir, regarding this, so you can stop sharing here.
Yes, I stopped sharing now. Thank you so much. Yes.
Yeah, definitely. So we will see you next week, and we will talk. We can collaborate with each other. We have lot of things together, especially sharing knowledge. So this is the most important. And as you have mentioned, in this Central Asian states, then this will be hub of training for youngsters, and this is the need. Sir, my question regarding now, after 17 years that you're doing bariatric or metabolic surgery, what is your main concern when you're going to do a bariatric surgery or metabolic surgery? So definitely think about this. Yes, this patient and like this. So what is your main concern?
Yeah, the main concern I think from all of us is when you have a leakage. Yeah, the fistulas. This is when you remember, but I'm so happy in the last 5 years, the number of fistulas of severe complications is really decreasing. That was because of technical reasons. We have now the power stapling. Yes, and this is, but that was my nightmare over the years. But I'm so happy that I have these endoscopic skills. I can do suturing, and I can do everything in laparoscopic approach. But this is, if you ask me, this is over 17 years, that was the highest problems. And on the other side, I love this kind of surgery now because we have a wonderful setup. And I have now exactly the setup of Munich here in Tashkent in our urologic hospital. We have another hospital, and the TIMC building is under construction. So we hope we can open end of 23, beginning 24. But you need the technique, and we have to teach. So we have to go to our young fellows to help them, and they should not experiment by themselves. So this is maybe my nightmare. If I can hear that experienced colleagues let young doctors do something in their OR and they don't support them, I think this is the biggest mistake what we can do. We should be with them. We should help them. They should have a good feeling, because our patients are so grateful and so thankful when we do good surgery. This is amazing, and they believe in our skills, and we should take respect for this point. This is my message after 17 years of
Sir, excellent. Sir, really excellent. And also, if you have any message for our youngsters who are just now going to start bariatric surgery and metabolic surgery. Please, sir.
Go for it. Look for a good teacher. So maybe Talal is listening to me. Talal is my old friend and colleague from Kuwait, and we are still in contact. So I hope that you have your teacher who is always with you and supporting you, and then be critical all the time, be ambitious, try to make the best in every surgery, and never believe you are godfather of something. The problem is your next surgery. And that is my message. Yeah? So stay always.
Sir, so much thanks, really. And it's a great honor. It was, in my opinion, one of the best sessions, because you have demonstrate in detail metabolic impact of this metabolic surgery or bariatric surgery, and how it works, and how we treat this diabetes type 2. And definite our viewers, this was a fruitful session for them. Sir, so much thanks, and my viewers, so much thanks, because till this time now I know in India this is the late night, and also we can go ahead, and we have a lot of viewers, and this session, they follow the session, and also this interview series is due to their follow-up. If you have any question, you can ask in comments. Professor will answer, because sir, now we are live on our Facebook group, Global Laparoscopy, and that is always we live, and also we will have some questions from our viewers. Sir, again, so much thanks, and my viewers, special thanks, because due to your support, I am able to continue now about 2 years. So this interview series, and next week also, in Tuesday, 10 p.m. Dubai time, we will be with another legendary bariatric surgeon. Sir, so much thanks again, and see you soon in Tashkent.
Inshallah. Kata Rahmat. Thank you so much, Imran.
Thank you, sir.
Wonderful. Wonderful. Great pleasure. And see you next week.
Sure, sir. Sure, sir. Thank you, sir.